we call it a cadaver, but it's just a body that is used for studying anatomy. So we don't call it a body, we call it a cadaver. And so each of us, each group was given their body, and you have to preserve that body for a whole year. Internship, I had done about maybe 150 CS in 1 year. When we reported to Kironyo the first week, and we went to the anatomy lab, we were first of all given body parts, human body parts. So unapewa mkono, unapewa mguu.
Hello my viewers, and welcome to today's episode. Today's episode we're going to talk with Dr. Kironyo, who is going to talk about his experience both in medicine and orthopedic surgery. He brings in all that experience to us.
Hi viewers, as Pauline has said, my name is Dr. Kironyo. I'm a resident orthopedic surgeon at Kenyatta National Hospital. And orthopedic is my thing. That's what I do every day.
So Dr. thank you very much. Actually, thank you so much for believing in my dream. I just gave you a call the other day and you just said, let's do this. Why not? Why not? You are one of those doctors who everybody would want to work with. You work with so much ease. Do you ever get stressed?
People have told me that you rarely get stressed. I'm an easy person. I'm an easygoing person. For me, I always follow Murphy's law that says if something was to go wrong, it will go wrong, and if something was to be right, then it will be right.
And that is very interesting, especially when you're working in an ICU and you walk in and you find very sick patients and you go like, who is in today? Dr. Kironyo. And everybody goes like, today's shift is going to be calm. And that is how everybody just calms down and does everything up and about, and the shifts end up so well.
Yeah,
so what's the secret?
For me, I just wake up every day and imagine that this will be the best day ever. And so even when things are looking bad, for me, I always believe there is that one thing that will make the day the best ever that I have ever lived. And so for me, even when I go to work and the first thing I meet is a full ICU, a full theater, a full casualty, for me, I always feel it's something good that will come out of this.
Have you ever had a difficult day at work?
People would say you had a bad day, but for me, in myself, I always feel like it was just like any other day. Maybe it was a busy day, but not a bad day. Working in this field sometimes can be tiring. You go to work, you're overwhelmed. You can only do what your body can be able to manage. You may have 10 patients, you may have 100 patients. Just focus on that one single patient you are treating at that particular time.
Exactly.
Because you cannot be attending to 100 patients. So the most important patient is the one that is in front of you. And that's the one that you attend and give them the best.
How was growing up for you?
I would say my life was just a normal life. I grew up in the village, somewhere in Nyandarua. Went to a normal village primary school. Later came to town and attended high school at Thika High School.
Oh, Thika.
Yeah.
So you know Thika like from...
Thika has been my village. I mean, people say I'm a local person.
Yeah, because if you went to school in Thika, that means, some of us went to school in those villages where everybody there, there's nothing big to see there.
I would say not really. I'm not a city boy, in quotes. I would say I was just a village boy who migrated to town. And so I was just living a normal life. I grew up in Makongeni. So for me, I used to wake up early in the morning, study, and do a lot of group discussions. Again, I'm a very social person. I'm not able to just sit somewhere and study on my own. I want somewhere I can make a few stories, then back to the book, and that's the kind of thing I do. So for me, I embrace a lot of discussions. Even today, whenever I'm doing a task, I would want to do it as a group, not like an individual.
Yeah, that's interesting.
Yeah, and so from there to the university, I went to the University of Nairobi. I did my 5 years of undergraduate degree, MD-CHB. Graduated and then worked as a medical officer for some few years.
When did you back? let me take you back to Nairobi University. How was life in Nairobi University?
For me, I have always had this dream of going to the University of Nairobi, and so being in the surroundings of the university, first of all, that gives me a lot of satisfaction.
How was training in that school? You know, we used a Kenyan education system where teachers are very tough, lecturers are very tough. Like it brings so much tension to the learners. Is it necessary? How was it?
I would say medicine is a tough training. When we reported to Chiromo the first week, and we went to the anatomy lab, we were first of all given body parts, human body parts. So unapewa mkono, unapewa mguu, unapewa kichwa, and first of all we were like, this is what we came to do, and some people quit medicine at that point.
I can imagine.
And so we were going to the lab. You are given the hands, and ultimately we were divided into groups, and each group maybe of 5 to 6 people were given. We call it a cadaver, but it's just a body that is used for studying anatomy. So we don't call it a body; we call it a cadaver. And so each of us, each group was given their body, and you have to preserve that body for a whole year, using it to study. So it was very structured in a way that today we are going to do a dissection of the hand. And so each of us has a manual that guides you on how to do that dissection of the hand. And so once you're done with the hand, that hand comes off. You go to another part, maybe the lower limb, and then you finish with that. Come to the chest, come to the abdomen, the pelvis, and all that, until you finish. By the time you are done, your cadaver is normal. You only have bones that you have preserved somewhere, and some vital organs that you used to preserve, maybe for the sake of other students would come to learn, and even for the examination, because we would preserve things like the heart, the lungs, and so on and so forth. And the bones, of course, all of them are kept safe in a cabinet.
How was your first experience when you had to really have a surgery or conduct a surgery on a human being, actual human being?
The first surgery that I did was during my internship when I was alone. And my consultant was around. I did my internship at Kijabe Hospital, AIC Kijabe. And the training there was really smooth. First of all, you would operate with a consultant. Day 1, day 2, you operate with the consultant again. And day 3, he sits somewhere in a room within theater. He's probably having their tea, tells you to start. I'm coming. Then you continue. He doesn't come, or he keeps checking the room and ask, is everything okay? And then one day when I was just alone, I called the consultant and told him, I'm going in, I want to do an emergency CS. And you just proceed, I'm coming. Then I went on, proceeded, I cut through the skin, got into the uterus. The consultant, I'm asking myself, should I wait for the consultant so that I cut the uterus to remove the baby? Then the anesthetist tells me, continue. So I cut the uterus, removed the baby, and the baby was a bouncing baby boy. And then the consultant didn't come, and I had to proceed to the end.
That was awesome.
Yeah, the mother did very well, the baby did very well. Then that's how I got my confidence. By the time I was done with my internship, I had done about maybe 150 CS in 1 year. So that's how medicine is trained. Medicine it's not something that you tell someone that now you're okay to. You can now go ahead, and it's like a military training. You are shown something, then you are left to do that and even go a step further on the same. So it's not time that the consultant will say, I've trained him, he's not good to do a CS, I can allow him to do. It's just stepwise, challenges you to do one alone when he's around, and then he sees how you've done the first one, then he gets confident with you. He says, you can do one even when I'm in my house, and then you can do one even when I'm away in Nairobi, and so on and so forth.
Did you at any time feel like, no, I can't do this?
Medicine. No, I've always wanted to be a doctor. So, my family always wanted me to be a doctor. So every time I used to feel like it's a bit difficult, I would look back and see the people who would be disappointed by this. And I felt, no, I need to keep going. And you know, medicine is very funny. The moment you join first year, people will really think you are a doctor.
Exactly.
So in your first year, people are already bringing their X-rays to you, they're bringing their CT scans to you, MRIs, they come and tell you, na umeona hapa, hebu niangalie. And it's your maybe your first 2 months in your undergraduate. So you don't know much.
And you cannot judge them. The community is extremely proud of you.
Yeah.
So we have a doctor. Let's go.
So you become a doctor immediately. You
learned in training school.
Yeah, and even the training, the consultants will start referring you to as a doctor, even before you even graduate. So even before you graduate, then the name doctor is already embedded and engraved in you. So I kept going, knowing that one, I wanted to become a doctor. Number two, I had a lot of passion for it. And number three, the community where I came from and the family members, they really wanted me to be a doctor. So there's no way I would have disappointed them.
So now after you've done with your degree and you graduate, how was life? How was the transition in life? Did you immediately get a job?
One is that during our time, currently there are a lot of challenges with the internship payments, getting that stipend. During our time, I actually finished and we graduated on a Friday, and the following Monday was a major doctor strike in this country. It was called Nipakam Attender Strike.
Wow.
And we stayed home waiting to start our internship for about 6 months. So you've graduated, you don't have a license, you've not done your internship, so you're waiting at home. But I found myself busy still working in hospital environment. I worked somewhere in Kilifi. And then then after 6 months I started my internship. That time internship was well paid. Used to get a good pay. And then the government would pay you in lump sum after 3 months. So I got a lot of cash. And then the first thing I'm like, where do I take all this money? You know, because a lot of money. You used to go for holidays, enjoy yourself, buy the best shoe for yourself, treat yourselves to the best restaurants in Nairobi, and so on and so forth. We enjoyed. And then after 1 year, we finished. Again, that time there was the transition from the national government to county government in terms of health devolution. So there were no automatic jobs. So you had to apply maybe to a county hospital or something like that. So I applied and I was hired by Kiambu County. So I worked for Kiambu County for about 2 years. Then I decided to go back for my master's.
Let me tell you that you're among those people who are so lucky. Because the way I'm listening to your story is like everything is just moving by itself. Do you know there are people who have graduated and they're waiting for those internship opportunities? They don't even get jobs.
Yeah, I know that's true. I wouldn't say I'm lucky, but I would say sometimes things just happen, and sometimes life flows smooth and in your favor.
Sure.
So I look at the current interns. They are underpaid. They don't get immediate jobs after internship. We used to get gross of around more than 200,000, around 210. Nowadays they are getting 70,000 after deductions, statutory deductions, pay and everything. It gets like 45,000. Times have changed, but all is not grim and dark. I think things will get better. What I would advise people is to keep forging ahead.
Better days are. Let me talk about your internship.
Yep.
We were having cases in Kenya where people are reporting that internship is extremely hard. What is really going on?
One is, I would say internship has always been hard. You know, you're coming from, it's a transition from being a medical student with less responsibility in terms of patient care to a doctor now who is in charge of patient care. And so a lot of expected from you. And the learning curve is very steep. You only have 1 year of internship, and in that 1 year, you rotate in 4 departments. So basically surgery, internal medicine, pediatrics, and maternity. And so taking a year divided by those 4 rotations, it's 3 months. In 3 months, say in maternity, you are supposed to be very competent and be able to do emergency surgeries like CSs and all that, and ectopic pregnancies. And so there are a lot of expectations. And if you're working probably in a government facility, say a level 5, it's a very busy facility. So you work during the day and during the night. There is no off. So basically, you are there every day.
Exhausting.
And it's exhausting. And by the time you're done with your internship, you feel like you're really exhausted. A lot of issues to do with the stress management, coping with the work-related stresses and all that has made internship to be difficult. But I always tell and advise interns to brace themselves. It's a tough year that really shapes your career.
Should somebody look for maybe mental health support?
Yeah, if you feel overwhelmed, don't keep it to yourself. Share with your colleague. Share with your consultants, with your supervisors. They are always willing to help. Sometimes the problem is people may not know what you're going through. Always have groups of friends that you can share with, and that can always be escalated. You can get an off, go through mental counseling to help you to finish your internship. And of course, people are different. There are people who are overwhelmed, others are hardy, and they can go through. And note that those that go through stresses and depression during internship are weak. We are wired differently. I always tell people that me and you, subjected to the same level of a stressor, will react differently. And so it's just to understand those that are going through difficult times and help them to overcome.
Because it is extremely sad. I remember last year we had a case where an intern committed suicide, and the case was attributed to the supervisor.
Okay, I remember that happened at Gatondo level 5. Actually, it was very sad because I had met that intern about a few days earlier, and we became friends. And the next thing I hear, she has committed suicide. I wouldn't say that the supervisor was really rough on her. I have interacted with all the consultants there, and I would say they are very friendly and they are very willing to teach. The thing is, sometimes others are a bit strict and others are
and to be honest, we need people who are strict, because we also don't want to allow graduates to go out there without much experience.
Exactly. As I said, is that this training is like a military training. You really have to ensure that the people going through your hands are competent enough. You know, I always tell people that if you have a student who is not fully trained or half-baked, one day they'll be treating you. They'll be treating your folk, they'll be treating your mother. So it's as medicine, one of the key tenets of medicine is, yes, to treat, but also to train. And so we take that seriously, and we always want to ensure that the people that are going through your hands are very well trained to handle you. I always tell people that if I get sick somewhere, I'm in Kitui and I'm sick, probably it's the intern that I trained who will be the first to respond and take care of me. So that's why we always feel that you need to ensure that the people that are coming to your internship center, wherever you are, that people are getting better and better, and they are safe doctors who can handle patients competently.
How did you transition from now medicine to orthopedic surgery? Have you always wanted to do orthopedics, or what inspired you?
So the funny thing, I tell people I wanted to, I decided to do orthopedics even before I did medicine. And this is how. I used to take my mother to an orthopedic surgeon when I was just after Form 4, and around that time, during our time, we used to wait for 2 years to join campus. And so around that time, my mom had an orthopedic issue, so I used to take her to an orthopedic surgeon, and I just admired how he used to handle my mom. I started feeling like that time I had basic basic understanding, the biology.
The biology.
So when he mentions a femur, and I know the femur that I used to see in my
that time biology was working with bones. Like
yeah.
Bones, and you draw this structure and you draw
exactly. So I just felt, this Daktari is talking about bones that I know. When I went to Chiromo for my first year, I found that he's a lecturer there, and we had already become friends. So he started talking, and he used to motivate me and to inspire me to do orthopedics. So people, even when I was doing my undergraduate degree, I knew I would just go to it. And even my classmates used to joke with me, if you don't do orthopedics, tutakupiga viboko.
Wow.
So I knew this is what I want. Yeah, so usually in medicine, you take the first degree, which is MD-CHB, or the undergraduate degree, and after you graduate, you become a general practitioner. So yes, you are a doctor, but you can't say I'm a specialist in this field. So you become a general practitioner. And then when now you go for your master's, you choose a field that you like, or which probably you feel like fits you. And so if you choose pediatrics, you become a pediatrician. You choose obstetric gynecology, you become an obstetric gynecologist. You take a neurosurgery, you become a neurosurgeon. So for me, I just decided to do orthopedic surgery, which deals with joints, bones, and muscles. Yeah.
So how soon do you choose a specialty and actually study for it? Because there are courses where you have to finish a certain period of time before you specialize. How does that go?
In Kenya, there is no limit. I think as long as you finish your internship, you can start immediately. Of course, many people choose to work for a few years, either to gain experience and to be grounded in the field of medicine, and then go back. But there are people who still go back immediately and they do just fine. Actually, I would encourage young doctors to go back immediately. Makes you go through this when you're young, and you graduate as a young consultant, and you are able to practice for long. Yeah. Sometimes it's always good. Many people feel that it's always good to work for some few years before you embark on your postgraduate studies.
When choosing a specialty, what are things that you should consider? Because I have seen people. I once encountered somebody who is already in a certain specialty training, and they go like, now why did I choose this one? I wish I could have done this. And then I want to go back. You can't go back. You're already in the middle of it. What are the considerations?
Well, that's very true, and it affects many. I would say number one guiding principle should be your passion. Because whatever you choose is what you'll be doing for the rest of your life.
Yeah, sure.
Say I've chosen to be an orthopedic surgeon. I'll be dealing with bones for the rest of my life. And so your passion, the thing that you can imagine, if I say I did pathology, then but my passion is in orthopedics, and then I'm working at 2 a.m. to do something that I don't like. You will feel very bored. But if you have passion in a field, even when it's stressful, you still feel like this is my area. Number two, I always advise people to ask yourself, is the market ready for me? Some people have trained, have gone to specialties, but even go out of the country, do something, and then you come back and realize, this specialization is not, the market is not ready for me. Take for example, I have my friend who did anesthesia, then did a subspecialization in anesthesia. It's called neuro anesthesia. But then she was working for Garissa County. So Garissa County had challenges with ICU, theater that can handle a neuro patient. So yes, you are working in that area, but the environment is not supportive and cannot accommodate your skills. So those are the two things I always feel they are really important. But for us, orthopedics, we are always busy because of the many fractures we see and trauma because of road traffic accidents, especially the motorcycle accidents. You realize nowadays we have a lot of boda in Ubers and everything. Basically, in this country, there is nowhere that you can't find a boda. and we get so many road traffic accidents, either pedestrian that was hit by a boda boda, or a boda boda was carrying 3 passengers that then veered off the road and lost control. So we get a lot of fractures. And so I felt, even though I had passion, I felt that there are so many there's a huge number of patients who need orthopedic care. And so that really pushed me towards that field. So orthopedics and basically surgery, you see a lot of injuries. You see gunshots, wounds, like recent Gen Z demonstrations. I was working at KNH and we saw so many gunshot wounds. A bullet, AK-47, shatters the whole bone, and you're wondering, how do I reconstruct this? We have some patients who come, maybe run over by a truck. Recently we had one who was run by a truck around over the waist, and the whole pelvis was crushed. So sometimes you see those ones and you are like, you're scratching your head, how do I proceed? But through consultations, discussing with peers and colleagues, you always get a way out.
Yeah. There are these injuries where maybe a certain accident happens and somebody has an injury where there is an amputation. Do you reconstruct? Do you have such modality in Kenya where you can reconstruct and maybe reattach the arm?
Yeah, we have had successful surgeries of what we call the implantation, but there are so many factors to consider. So not all limbs can be salvaged. Take for example, if I have a sharp finger cut through my thumb, and that thumb is kept in optimal conditions, ideally, say, wrap it in a gauze, then put it in a polythene paper, and then in a cool box, and then taken to the hospital before 6 hours. That's something that can be salvaged. But again, the same finger, if it is crushed, it cannot be. It cannot. So there are so many things to consider, but we have had successful surgeries. Of course, Kenya has its own share of challenges in terms of available resources, available expertise. If you're talking about 6 hours and you're coming from northern Kenya to Kenyatta, unless you're using a flight, so which is again difficult. So there are so many things that comes into play whenever you are thinking about the implantation of a limb, and that's why most of our patients end up getting amputations because they do not meet the criteria for the implantation of a lost limb or a part of the limb.
For those that happens in the interior and they don't have the goals, they don't have what are they supposed to improvise?
If you're in the bush, you are in a remote area, you can still take a clean piece of cloth and it should be damp. So basically, wet it, preferably in a clean water. Then wrap the parts and then put it in a cooler box. If you don't have a cooler box, you can get ice. I know again it sounds, if you're in the interior, getting ice, getting a cooler box becomes tricky. But you can always run to the nearest health facility. They should have a cooler box, and then they can help you with the cooler box, and just to facilitate the transportation of the patient and the affected parts to the hospital. Ideally should be less than 6 hours.
Less than 6 hours.
Yeah.
Yeah, because I think I have had such a case in Kenyatta.
Yeah.
Where they had an implantation of an arm.
Yes. Those have been done. Now it's sometimes the challenge is it's done by a team of doctors. Orthopedics will deal with the bone. The plastic surgeons will come and deal with the tendons and all that. And then you need a vascular surgeon to come and attach the vessels. So it's a big team, and the surgery can take long hours. So it requires a dedicated team. Yeah, and the team, I would say, is always there. The problem is meeting the criteria. Sometimes patients is coming with the limb 10 hours after. So the patients end up getting an amputation. Yeah, but those are things that probably we can we need to focus on and ensure that patients get to the right facility in the right time.
Okay.
Yeah.
Is there a population that is very prone, very at risk of getting fractures? Not necessarily.
Yeah, that's of course generally men explore a lot. You look at the people who drive Subarus, young men. People that are riding boda bodas are young men. Even the passengers that are on the boda boda, mostly they are young men. Men who have bought the latest sports car or an SUV, they want to experience it, so they drive very fast. So basically, the young population and men. So if you compare men versus women, men will tend to have more fractures, more injuries as compared to ladies. And if you take the young versus the old, the young ones will tend to get injuries. The young ones they explore a lot. A young man will be on top of the tree in the village harvesting mangoes and avocados. You know, we usually get this whenever it's the season for the mangoes. Of course, you realize most mangoes grow in Ukambani. So we get a lot of spine injuries coming from Ukambani when it's the mango season. Then kwa watu wa Murima, whenever it is avocado time, boys are harvesting avocados, and then they fall from height. So you get this kind of fractures around the time when there is avocado time in the central area of Kenya, and maybe mangoes. When you go to areas like the Rift Valley, because I have also worked in Nakuru, we again see a different kind of injuries. Mostly from the highway, the Nakuru Eldoret highway, so get so many truck accidents. But also a special one is people who harvest timber in the Mau forest. So they get injuries carrying those logs, and so we see again a different kind of injuries from that area. People that are old, the elderly, their bones are soft. So a small fall, a trivial fall will cause a fracture. But the same kind of fall in a young person would not necessarily cause a fracture. So those are called fragility fractures. Yeah. So this mainly affects the elderly, especially women because of low levels of estrogen after menopause. So they get the bones becomes very weak. And so there are some interventions that we do to help with that. Yeah, so we see those variations.
Yeah, you can share with us the recommendations
for
to prevent the fractures.
So of course, for the young and the road traffic accidents, this one involves a lot of people. So the question is, will we tell them not to ride boda? Of course not. Maybe the campaign will focus on ensuring that the riders follow the traffic rules. They are always on their helmets. They are driving safely and in the designated areas on the road, and within the right speed and obeying street lights and all that. Again, carrying the required number of passengers. Yeah, so those are things that probably we can work together with the police and the government to enforce these regulations. Again, for road traffic accidents, the same. Much falls onto the government about regulation on speed control, safety belts, and all that. You know, for the elderly, those that we feel that they could have weak bones and are prone to fragility fractures, we usually give them medications, calcium, vitamin D, and even hormonal replacements to ensure that the bones remain strong. Yeah. There's another subset of fractures that we call pathological fractures, which happens in a bone that has a defect, probably has infection, cancer affecting a certain part of the bone, and so it weakens the bone. So a patient will get a trivial trauma and the bone fractures. So those ones, again, early treatment, diagnosis and treatment helps to deal with that.
Okay.
Yeah.
What are some of the challenges that you feel that the healthcare is facing?
Currently, we are talking about Shisha, and one of the greatest challenges we are facing currently is funding.
Mm-hmm.
Let me talk about orthopedics in particular.
Mm-hmm.
For us, it's not just about, much of the work that we do involves putting an implant, otherwise known as a chuma. Mtu anakuambia nimevunjika mguu naenda kuwekwa chuma. And so the hardware or the implants that we use are usually very expensive. So sometimes patients are not able to afford. Sometimes they are not registered with SHA, and even sometimes the hospitals are not willing to accept the SHA cover. So much of what we see is challenges with financing, and this is something that the government really needs to think about. Healthcare financing is very expensive. I always tell many of my colleagues, we are very poor. Because take for example, if you need an ICU right now, many public hospitals don't have ICU. If you are to go to a private hospital for an ICU care, an average admission cost will come to around 400,000 with a daily accumulation of about 100,000. So the question is, how many people can afford that? And if you are saying that SHA is taking care of this, how many facilities are accepting SHA and willing to cover for ICU care? So it's difficult. So healthcare is very expensive, and we really need to start thinking about healthcare financing. It's one of the biggest challenges we have, not just in orthopedics, but across board. Patients with cancers, they spend a lot of money. Patients with kidney diseases who require kidney transplants, dialysis, and all that, it's a tall order for them to afford the huge costs that involves that kind of treatment.
Do you have enough personnel?
I would say currently we have enough. The challenge is hiring those personnel. We have so many doctors who are jobless right now. Yet when you go to the hospitals, they don't have enough doctors. So doctors are available around here. They are here looking for jobs. Nurses the same. Clinical officers, name it. But job opportunities are very few. The government is not hiring as we would want. The union has been very vocal, pushing the government to hire doctors. There is a recommended WHO patient-doctor ratio, which we are very far away from achieving. And so I would say we have a lot of manpower that is underutilized. And that's why many nurses are flying out of this country, going to the UK, to the US, and to Australia. Not that they don't want to work for this country, but they are looking for greener pastures. Yeah. So
when we don't have enough numbers, we find that the quality of care is compromised.
Definitely. And whenever you don't have enough workforce in a hospital environment, the patient care is compromised. Take for example, if you have a mass accident and say about 20 patients are taken to a hospital, do you have enough doctors? Do you have enough nurses? Do you have emergency care providers that are well trained to take care of such huge number of people? So whenever we don't have enough manpower to offer healthcare, the patients always get a raw deal. Patients may not be aware, they may be unconscious, and many will succumb to their injuries, to their diseases, just because we don't have enough manpower in those hospitals to take care of those kind of patients.
And I think this is a call to the government to ensure that we're having patients deserve good quality of care.
And the government has that responsibility to offer care to all its citizens.
And care, good quality.
Yeah, we're not just talking about care, it's good quality care that meets the international standards. But what happens? You might be a doctor in a hospital, but you don't have equipment that helps you to take care of the patient. If I'm a surgeon and I don't have a theater, I'm just like a layman because I need equipment to work. I need support staff. I need an ICU. I need nurses. You don't work alone because you're a surgeon. Uh, you work as a team. And so whenever the team is not complete, again, patient care is compromised.
That is really interesting. Thank you so much for sharing your insights. So, Doctor, if there was medical myth that you would want to debunk.
Specifically in orthopedics, many people have always felt that orthopedic surgery is for the male gender.
Mm-hmm.
Of course, orthopedic is you use a lot of physical energy.
I'm telling you.
Many people who come to our theaters think we are carpenters. They'll find a drill, they'll find a saw, they'll find chisels, they'll find mallets, hammers. Because we deal with bones.
Yeah, you feel like construction is going on.
And there's a lot of physical energy required when dealing with an orthopedic patient. And many have always thought that this is a course for the men because men are deemed to be strong. But we've seen recently a number of women joining orthopedic surgery. It's interesting. One thing I would say is that orthopedic itself is so broad. People have subspecialized. There are people doing orthopedic oncology. There are those that go to pediatric orthopedics. There are those that just go to spine surgery. There are those that just go to joint reconstructions, otherwise known as arthroplasty, arthroscopy. There are people who just specialize on the pelvis. So the area is so broad, and we've seen ladies joining orthopedics and doing very well.
And when you talk about spinal surgeries, the spine fractures, how bad are they?
Spine surgeries are devastating. You realize the continuation from the brain, you have the spinal cord running in your back, basically protected by the spine. The spine is primarily designed to protect the spinal cord. And so whenever there's a spine injury, in most cases, then there will be a spinal cord injury. And whenever you have a spinal cord injury, it basically comes with neurological deficits. So probably you have weakness in your lower limbs, otherwise known as paraplegia. If it's occurring high in the neck, you lose the power to your hands, to your legs, and even sometimes to what we call the sphincters, basically the ability to control your bowel and bladder function. And so those injuries are very devastating. Someone who was walking could do things for themselves, and all of a sudden they can't walk, they can't use their hands, they are bedridden, they have to be turned in bed, and so on and so forth. So spine injuries are devastating injuries. We've seen an increase in that again because of the border accidents and road traffic accidents. Again, we see them in people falling from heights, in construction workers. Someone was probably painting on the 11th floor and then come tumbling down and have their spine injury. So it's not one of those injuries that we like seeing, but unfortunately we still come across them quite a lot.
In a situation where a patient has had that accident, in the manner in which we handle that patient?
In orthopedics, we always say patients who come to you, significant road traffic accidents, it's you to gauge. Someone tells you I was in a car, 3 people died, I'm the only survivor. Just in your mind, you should know that this was a high energy injury. Someone tells you I fell from 4th floor to the ground floor. So all those patients, we always suspect spinal cord injury. And so the first thing that we do is to ensure that the patient, number one, are handled in the right way. if we are transporting such a patient, we don't want them to be turned anyhow. So there's a transfer board that you should place the patient flat on a hard surface and carry. You've seen those that they use in football match games. Patient gets injured and is carried by 4 people. When in the hospital, again, whenever we are turning, we prefer what we call log rolling. So we turn the patient whole. And then because cervical spine injuries carry the worst prognosis, we always put a patient on a cervical collar even before we are certain that there is such an injury. You assume there is one, and so you put the patient on a cervical collar to ensure that there is no continued or what we call secondary spinal cord injury. Because the primary is going to happen at the side, but because sometimes you can have the spine that is very unstable, the more you move and the bones are moving, they are causing more injury to the spinal cord. Yeah.
Okay, so supposing it happens there in the village?
This is one of the challenges we get because people who come to rescue patients in an accident, in a construction site, they are not primarily healthcare workers.
Sure.
And so they don't have this kind of knowledge on how to handle such kind of a patient. What we should do is to ensure that we are educating the masses to ensure that they have basics in handling patients involved in trauma.
Do you see yourself doing this? Until when do you think you were going to do this?
Although it's interesting. One thing about orthopedic is you see instant results. And that's one thing again that made me join orthopedics. Take for example, someone comes to you with a femur fracture, they are not walking. You take them to theater, fix their fracture, and tomorrow in the morning they are walking. So you see instant results of your work.
Wow.
And so that's one thing that I love about orthopedics, and it's very fulfilling. So for me, I feel like this is what I want to do. I want to specialize in future. I feel like my heart is taking me to spine surgery.
Wow.
So that's probably in the next 5-10 years, I'll be doing a lot of spine surgeries in this country.
We are wishing you the very best.
Thank you so much.
So now, Dr. We have prepared a pulse check minute for you. So we're going to check whether you're doing well.
Right.
Just for 60 seconds.
What does it involve?
It's a quick fire question.
Oh my goodness, I don't like quick fires and exams.
We are going to start with a yes or no question.
Good.
Do you feel you have control of your workload?
No.
Have you recently laughed or experienced a joyful moment despite your challenges?
Yes.
Have you been able to spend quality time with your family?
Yes.
Do you feel a sense of accomplishment in your daily tasks?
Yes.
Have you had feelings of hopelessness?
No.
Do you feel appreciated for the work you do?
Yes.
Be honest. Have you taken any time more for self-care in the past month?
Yes.
Do you feel you have healthy ways to manage your stress?
Yes.
Have you eaten regular or a balanced meal of late?
No.
Do you feel supported by your colleagues at your workplace?
Yes.
Have you experienced difficulty concentrating during your shifts?
No.
Do you find joy in activities outside your work?
Yes.
Have you been able to get enough sleep in the past week?
Yes.
Do you feel emotionally drained at the end of your work day?
Yes.
So we're coming to the end of our show. Dr. Where do we find you?
Patients willing to see me or to consult with me can find me at Vika Town in a building called Maisha Heights, second floor, a clinic called Kenai Spine Clinic.
So thank you so much, my viewers, for being with us. Thank you for following this very interactive session that we have had with Dr. Kironyo. And make sure you follow us on YouTube, follow us, interact with us, like, comment, share. We want to hear your views. Tell us your suggestions for the next episode. Until next time, see you then.